Hello, welcome to this webinar focusing on the Norwegian response to the coronavirus with Dr. Frode Forland. This program is produced by ASF, the American-Scandinavian Foundation. I am Edward Gallagher, president of the ASF, and will serve as host and moderator today. On March 15th, the ASF was forced to close its New York headquarters, Scandinavia House, the Nordic Center in America, because of the coronavirus crisis. Each year, the ASF presents more than 150 lectures, films, concerts, children's activities, and workshops at Scandinavia House. During this temporary closure, we are presenting a wide variety of these programs online, including today's webinar. Please consult the Scandinavia House website for further information and to enjoy our online programming. You can go to scandinaviahouse.org, and there you can also follow us on our social media channels. Now to our webinar, Norway's response to the coronavirus. It is a pleasure to welcome our speaker, Dr. Frode Forland, Specialist Director of the Infectious Diseases and Global Health Division at the Norwegian Institute of Public Health. Dr. Forland is a medical doctor and a specialist in public health and general practice. He initiated and led the Global Health Preparedness program under the Global Health Security Agenda. He has worked at the Royal Tropical Institute in Amsterdam and at the European Center for Disease Prevention and Control in Stockholm. Previously, he was Director of Primary Health Care at the Norwegian Directorate of Health and has worked several years in Africa and has served as a board member of Guidelines International Network. It's a great pleasure to welcome you, Dr. Forland.
Thank you. Good morning, everybody who are over there, and good afternoon if there are somebody from Scandinavia listening in. Thank you for this opportunity to speak to you a bit about the Norwegian response to the coronavirus. I will now try and share my screen, and then I will have an introduction first here and talk through a few slides, and then afterwards there will be an opportunity to have a discussion with you live. Okay. You can see the screen now, Ed?
Yes, looks very good.
Fine. That's great. So I'm working at the Norwegian Institute of Public Health, which is like a counterpart of CDC in Atlanta. It's the Norwegian Institute of Public Health, or the Institute also for Disease Prevention and Control. And our mission is to produce, to summarize and communicate knowledge and to contribute to good public health work and also to good health and care services in Norway. In this way, we hope that our institute contributes to better health in Norway and globally. So we also work globally or have an opportunity to take global initiatives where we have national competence and responsibility. So we have a separate unit also for global health, where I also partly are engaged in working on global health preparedness. Our key areas of work are connected to these three: knowledge, preparedness, and infrastructure. And under knowledge, we do research. We produce around 800 peer-reviewed papers per year. We do analysis of all the data that we are collecting, surveillance systems. We are also producing literature reviews and reports, news bulletins, and guidelines and handbooks. So in Norway, the Public Health Institute is also hosting the Norwegian Center for Evidence-Based Medicine, the Cochrane Center that some of you might have heard about. Related to preparedness, we are also having a lot of all ongoing activities, like we're a preparedness laboratory, which is open 24/7. And we also have an infectious disease control unit with a specific telephone number for all doctors of the country, with an officer on call. We have communication online every hours, and also we are the focal point of the IHR, meaning the International Health Regulation. And for those of you who are not familiar with that, it's the international health law, which is the law actually approved by all member states of WHO. I'll come shortly back to that later on, which is a requirement for all countries then to have an office in the country that is responding when there is an outbreak of any disease, for instance. And related to infrastructure, we have our surveillance systems for infectious diseases, a number of those abbreviations back there. And we're the reference lab for like 30 bacteria and viruses. And we also keep biobanks and registries. So it's like being a hub for all these functions for the whole of the country. And this ends up in recommendations, advice, information, publications, and so on. Shortly, a little bit about the disease pyramid related to COVID or coronavirus disease. If we start at the bottom of this pyramid, we can still see there are like three words there named in red, and those are the things that we don't know well yet. How many were exposed or are exposed, how many are infected without symptoms, and how many might have symptoms that we don't know about. And then we are coming up to those that we can see and can find a way of registering. And that's those who see their GP, those who have a positive test, those who are hospitalized, or those end up in intensive care, or at the end, we count the people who have lost their lives. And we have different sources of data for trying to keep an overview over all these different numbers. You see on the top here, it's easy to have the death registry. And then for intensive care, we have a specific registry for intensive care in Norway. We have a national patient registry for those hospitalized. And we have an infectious disease registry, which is also hosted by us for the positive tests. And we also get information about what were the diagnoses for everybody who have been to primary care through this KUR database. And then all these elements are actually now gathered in a specific registry called BERET, where we can pull the data together and try and understand more about the epidemic. For those below there, it's more difficult to get results directly, but we are now developing prevalence studies to try and find out how many have had the disease in Norway, looking for the antibodies. And also we started using an app to try and also help people for contact tracing, to try and find out who were you in contact with and where did you get your infection. And this is the standard curve for any epidemic. And you can see it starts slowly, it goes into a higher number, and then it tapers off again. And it's a window of opportunity here, which is painted in red. Before that, we have the prevention and the preparedness levels that should be always in place. And then we have always the opportunity for surveillance of the disease to try and find out when something happens. And then there is this early detection and hopefully rapid response that has to be taken to try and avoid a big wave of the epidemic. When the wave has started, we have control measures that can be put in place to try and control the epidemic in the response phase. And this is the epidemic curve for the COVID-19 disease in Norway from the date of tests taken. And you can see over here that it started in actually the first case is end of February, and then starting gradually in beginning of March, when we got back a number of skiing tourists coming back from Austria and Italy, infecting their families and also their working colleagues. And on the 12th of March, we saw a number of cases that we couldn't any longer, 2 or 3, trace the contact. And that meant we had actually an ongoing transmission of the disease within the country. And we saw the first death in Norway. And that's when also the government started to have strict measures and took over the responsibility from the health authorities, saying we need now an all of government response. And then we've seen the curve flattening out here and then going steadily down from beginning of April down to now. And we have now only a handful of new cases per day in the testing, and I think 38 patients left in hospital in the whole of the country. This is the curve for just showing the spread on the ages and between men and women. And we see there is a little bit of difference between men and women. And in total now it's leveling off to be 50-50. In the beginning there was most men, and then it seemed like they came back and infected their partners. And then we also see there is a higher number of women in the age group of 20 to 29, maybe females working in hospitals and nursing homes. That is my theory. And then you see at the end here, the number of deaths are a bit higher among men than women, even though there are more women being in the old age groups. And these are the number of tests that we have taken, or a curve showing on that. And the blue bars here show the number of tests, the red at the bottom, the positive tests. And the black curve is just showing the percentage on the right axis of how many percentage of positive tests we've had. So it's been like a 5% and now going down to a level of actually below 2%, around 1% of the tests. So there is actually now very little spread in the society itself. And we've taken like 230,000 tests totally. So around 5% of the population have been tested. So the strategy, I think, as it has been formulated in Norway, has been very close to the formulation given by WHO. It's to preserve health, to avoid societal disruption, and also to protect economy. And from the 12th of March, we had this all of government response. And the naming of this response was given by our Prime Minister to knock down the spread. I don't know if there's a good English word for that, but you understand it was like, knock it down. We couldn't say really fully stop it, but at least try and reduce it as far and as much as possible. And then there were massive measures across the society. Schools were closed, kindergartens were closed, social distancing was imposed. People were advised to stay at home, not work from their workplaces, try and avoid public transport and all that stuff that you've probably heard about, which has been not a full close down, but a very tough measures taken. Still, shops were open. You could go to shopping malls, also buying your clothes. You could even go to restaurants, but keeping distance. And it was then a rule of 2 meters between each and every one. And the most serious thing with this was actually to try and prevent overburdening the health services. So this was when we got feedback from how things were going on in Italy, and we saw the pictures from China with very overstretched health systems in local areas. And it was also to gain time to prepare at all levels of society. So that was the strategy from the 12th of March. And when we saw the curve flattening out, just before Easter, the government started with a new way of using the word, we are now in a process of controlling the spread, which was formulating that from the 20th of April, we will start gradual de-escalation of the measures and have a controlled reopening of the society. And then doing this at the same time as we do active testing, contact tracing, and isolation. So with an aim of finding each and every case and each and every source of each and every case and isolating ill people and quarantining those who are contacts. But still at the same time having this opportunity to be prepared for a re-escalation if need be, locally or nationally. So this is the strategy we are in now, and we have a huge capacity to test if need be. And we see very little spread now, but we have some minor outbreaks in schools and homes for the elderly, for instance, lately. So the reopening was a stepwise controlled approach from so far being planned from April up to August. First, it was opening the kindergartens and then the schools and getting people back to work as soon as possible. Now there has been like 400,000 people being off work due to this lockdown, and gradually the numbers are becoming less again. So it's an improvement ongoing. And then to try and keep social distancing and hygiene measures as long as possible. I think that's something which is not really a big burden to the society. And then, of course, to try and protect the vulnerable, those people, especially at elderly homes and in hospitals with underlying diseases. And we see that the risk factor above any other risk factor is being old. So it's actually age much more than any other diseases or any other background. And then later on, reopening leisure and fun, that has started now. People are allowed to start playing football again and doing a bit of activities and organized sport activities. Still, where there is a lot of contact, people are advised to stay away, and it's only for the higher level football, for instance, that they are allowed to have matches, and it's without audiences. So it's been like a whole of society and an all of society approach here. And our Minister of Health was saying we are now going from the critical awareness phase until getting this into our daily routines, which I think is a good way of formulating. And these are routines that we probably have to live with for a year, maybe for 2 years. And we need to find the right balance of the strictness of the measures and the ways we need to live together to be able to cope with this for the future without too much of societal damage. And at the same time, hoping that we can have also a global solidarity within our communities and between countries, and not just thinking of ourselves. So this is a real pandemic affecting the whole world. And I think there is a way of understanding and sharing, which is very much important here to try and combat this worldwide. And we think that the role of WHO here is crucial, and they have a very important role to try and also both collect data and to moderate responses in different countries. And just a few slides also on the gender perspective. In Norway, we saw that we have all the statistics have a gender as a variable. We've seen that more men are affected than women in the beginning, but this is leveling off. We've seen that men have been more prone to die of the disease. And we've seen, as I mentioned, age is the overarching risk factor also more than gender. And when it comes to the response, the leadership of the pandemic in Norway has been taken over by the leader of the country, Erna Solberg, and you know she's a lady. The ministry level was taken over by the Minister of Justice. She's also the Minister of Preparedness. She's a lady, Monica Mæland. And at our institute, our director of the institute is Camilla Stoltenberg, the sister of Jens Stoltenberg. She's a lady. And at our level, at the institute, the department level, it's Eline Wold who's coordinating the outbreak. She's also a lady. So I was just speaking to a group where they were very much interested in the gender perspective. So I thought this is also nice. There are like 4 strong ladies in the leadership of this pandemic in Norway. More important maybe might be to have an equity perspective on the global level. To see, I think also the preventive measures will actually disrupt economies for poor people, very much in low and middle income countries. And I think installing some of the European measures in Africa will be a disastrous way of doing it. It's a young population and they cannot work from home without electricity, without a computer. And how can you keep hands clean if you have no water or no soap in your house? And without travel and trade, there is no food for the day. So there are something here with these measures that are not at all possible to carry through, I think, in low income countries. And we've seen from Brazil, indigenous people being extra vulnerable, and they have had no access to tests and no labs to do the analysis in Africa, no hospitals with ventilators. And again, as we stress also in our work on global health preparedness, primary health care and universal health coverage is also fundamental for the prevention of COVID-19 and for the treatment and the response of COVID-19. It's systems that have to work in peacetime, and they have also to work then during a outbreak like this. And I think also the role of being a migrant or refugee makes it extremely difficult in this situation. And as I mentioned, there is an international health law called the International Health Regulation. And in the Article 2 of this regulation, it's written the purpose of this law is to prevent, protect, and control and provide a public health response to international spread of disease without avoiding unnecessary interference with traffic and travel and trade. So I think this is a regulation that really applies in this situation, and it has to be seen as a means of trying to also to show solidarity across countries, and not just seeing what can benefit my population when we are trying to grab for instance, equipment in a situation where there is a lack of equipment. And Dr. Tedros, the Director General of WHO, was saying when he was stating this public health emergency that in Article 44, it's written that all countries are obliged to support each other in the identification of the source of this virus, and also for its potential to try and understand human-to-human transmission. And it's written in that same paragraph that we should be obliged to support countries both financially, technically, and legally in trying to combat the disease. So coming to an end soon now in my talk, we have had a huge area of uncertainty in the situation, and we have had to try and build up the areas of knowledge and evidence. And in the beginning, we had very little evidence related to what will happen with this coronavirus, and a lot of the evidence about the measures were developed from previous influenza pandemics. And now we see we are doing risk assessment, rapid and more long-term, and we have more information ongoing. And we have tried to build up also a database in our institute, which is now available for everybody, where we are trying to map all studies on the coronavirus. And this is freely downloadable from our website, and you can find an overview over all types of studies related to background, from epidemiology, from treatment, from whatever there is, the virus and the immunity. So this is a help for everybody, where we are working also together with WHO, and it's for users all over the world. And we have a lot of interest in this, and we'll also publish this widely internationally. At the same time, we've done systematic reviews very rapidly to try and map some of the most pertinent questions that we have. What is the role of children in the spread? What is the role of contact, of the spread between touching items, the role between age and comorbidities and all that stuff? And these are all in English and also available from our website that you can read. So we started by writing them in Norwegian, but we found there was a huge interest internationally. So now we are publishing them in English with just a short Norwegian summary. So this is for all of you to look at if you are more interested. And just to stress again, the final thing, there was a very nice chronicle written by all these leaders from Italy, from France, from Germany, from the EU, and from Norway, that stating the need for the international solidarity. What we all have in common is that none of us can plan for or be sure of the future of this pandemic. This means that we are all part of this. None of us are immune to the pandemic, except maybe those who have already been through it now. And none of us can beat the virus alone. We will not be safe until everyone is safe in all world cities, regions, and countries. In our interconnected world, the global health system is as strong as the weakest link, and we must protect each other in order to protect ourselves. And this is really a call for working globally, I think, and supporting WHO in this work. And finally, a last slide, what will be the fate and the future? What is the scenario for the future? And there are 3 different scenarios written there at the right. And I think many people have been talking about the big wave to come when we have gone through the first wave, like the figure in the middle is showing a small wave and then a big wave to come. I don't think we will have a big wave there. I think and hope that we can have the last piece here, so showing a small wave that has been there, or rather big in some countries, and then small bumps until we have a vaccine. Because we have shown that it's possible to stop this. It's possible to mitigate it so much that we can control it. I think that is the situation now we're having in Norway. And whenever there is an outbreak again locally in a school or in a workplace, we will knock it down again by active testing and closing down a class instead of a whole school, closing down a workplace department instead of the whole factory, for instance, because people are advised to be in cohorts and knowing the groups they are in. And we have also advised to not being in big gatherings of people. So it's still only 50 people who are allowed to stay together. But from 15th of June, the plan is to open up for 200, as long as there is a controlled way of being together with names of the people who are entering a meeting arena, for instance. In private settings, only 20 people. So that is the situation. And then I think also we have to be very cautious about protecting health workers and also protecting the risk groups, the vulnerable old people. And finally, some learning points. I think the principles of preparedness, as we express them in Norway, they still are very much, I think, relevant, that those who have responsibility during peacetime should also have the responsibility when there is a crisis. We should try and solve this with a proximity to where it has come from in a similar way as normally, and with an obligation of coordination across. And there is all of the healthcare and all of society and all of the world, which involves this pandemic. And many people have talked beforehand about disruptive technologies that are changing the world fast. And I think what we see now is a disruptive event, a public health event of international concern. And I think this corona pandemic has an opportunity to change the world and change the society, and hopefully then to the better. I think there will be changes in the way we travel, the way we hold meetings, the way we move around, and hopefully in the way we're also dealing with nature and our closeness to taking over the areas where maybe the animals should be. So the question is, how can we live together in a globalized world without destroying the globe? I think that is where we are, and we should work on that together across nations and across the big seas as we are in now. Thank you very much.
Thank you very much. It's fascinating. Number of questions have come in, and first I would would like to just review the numbers in Norway. You have had, I'm sorry, how many cases? 8,000 approximately?
Yeah, 8,300, I think now.
And fatalities around 350?
250.
Only 250. Wow, okay.
235 was the last number I saw from yesterday.
And the profile of those who were most seriously afflicted and those who died, largely elderly with pre-existing conditions?
Yeah, largely elderly. The average age is like 83 years of age.
Mm-hmm.
And then 90% being over 70 years of age. Of those
and most of them living in facilities with other elderly people?
Yeah, most of them. But still, we have also seen some of these very normally healthy people dying in hospitals. So we had also a number of those cases below 50 as well, between 30 and 40. So that has been, of course, a lot of attention paid to that, but they are very few compared with the majority. So it's also a disease that can hit young people and seriously. Some of these people coming back from their skiing holidays and being totally fit, having died. And a number of people also coming back from their holidays in Spain, being pensioners, fit for fight and out there having their good time. There was an infection going on in a colony of people who lived there together. So there are some very sad stories, but still most of them are those people, as you say, with underlying conditions and living in homes for the elderly.
And you began contact tracing quite early on. You're testing and contact tracing, I assume.
Yes.
Have you been able to measure the effectiveness or success of that contact tracing?
It's difficult to say what is the effect of what here, but still this is an obligation to each and every municipality in Norway. And we've been able to trace most of them, but there was a period when there was this very rapid increase in Oslo that they couldn't trace all of them. So and then now we see again that the curve is going down, and the role of the municipal responsible doctor, the health officer of each and every municipality is to contact and get hold of all the contacts for every new case.
Was there ever any, I know Norway's borders are currently closed, I believe, aren't they?
That's true.
And at one point, there was even an effort to close borders of the various municipalities or regions. Is that correct?
Yeah, some municipalities up north and even some of the regions up north were saying we don't want people from down south coming up here because you have all the spread in Oslo. There is a certain logic to that, but it made a lot of trouble for people who are traveling for work across, of course, borders of municipalities. There are nothing like that except it's like an administrative region, nothing else, and people have been traveling around. But they kept it, and according to the Norwegian infectious disease law, it is legal to do that. But that's meant actually if you have a big outbreak of something in a local setting, but this is a pandemic. So there was this idea that we can stay away from it. And so far it's somehow shown that a number of municipalities in Norway still haven't had any cases.
Really? Okay.
Yeah.
And at this point, Norway will be fully open June 15th. Limitations on crowd sizes, but beyond that, businesses will all be open, and although borders closed.
Yeah, businesses have been opened in a way the whole time, but with regulations connected to the number of people being there. That means that restaurants closed down because they couldn't have so few guests and earning any money. And then there have been, a lot of challenges connected to all these mothers and fathers staying at home for their kids were not allowed to go to kindergarten and schools. And there were a lot of consequences of the lockdown that we are now gradually lifting. And people are coming back to work, and the prices, it seems now, for instance, on houses is stabilizing again. Airplanes have started to fly again, but with a very reduced number of flights. Buses and trains and public transport has been open the whole time. And at the same time, people are advised in the cities to walk and to use bicycles and to be few on the buses. So every second seat is always occupied by a cross. And still at the restaurants, it's obliged to be 1 meter apart from each other.
I've heard from many Norwegian friends that you had a very strict regulations about older people seeing their grandchildren or younger people. Is that still in effect, or has that been lifted?
It's partly in effect. I think we've said that they can see their grandchildren, but they shouldn't do a lot of hugging and a lot of kissing if these kids are in a kindergarten. And of course, that is because the elderly are much more vulnerable to the disease. And for visiting people who live in nursing homes for the elderly, we have also rather strict regulations, and they should meet in separate rooms. They shouldn't walk around into the areas, the common areas. And also the use of face masks is advised in such a setting, because we saw in the beginning that a number of people brought the virus into these facilities, into the hospitals and also into the nursing homes without knowing that they had a disease. They just had a little cough. They were just having a flu or a cold, and then people come and see their people. So it was both by the health workers and by the people visiting the old people that this was brought into these facilities. And actually 60% of our deaths has been from people living in such institutions.
Okay. We have several questions, a number of questions from our participants, our viewers here, and I'd like to ask you a few of them. One of the first questions here was, what has the effect been on the Sami population? Have you been able to gauge that specific group of individuals?
No, I don't think it has. There has been extremely little spread in the north, but one of the few first cases was actually cases that came with tourists from China to the north of Finland, and some of them also moved over to Norway. So that the first reports we had actually about somebody being infected came from the north of Norway, from Chinese tourists in the north. But so far, it has not really affected the Sami population any worse than anybody else. What we've seen is the hardest hit population was foreign-born people living in Oslo, as immigrant populations in Oslo, and we think it was mostly because of a language challenge in the beginning. Now all our advice has been translated into 41 languages, and we've had films being produced in 20 languages being spread all over. So that, and the numbers again have gone down to the same level in those part of the city and those populations as for the Norwegians who are also born here.
Mm-hmm. Another question. Norwegian and Swedish measures seem similar despite being portrayed as very different in the media. Would you like to expand upon that? Norway is more open, I think, has been more open than many people realize.
Yeah, I think the biggest difference, as I see it, between Norway and Sweden, as Norway started by installing the measures very tough and abrupt on one day on the 12th of March. In Sweden, the measures were installed more gradually, and now they have been de-escalated gradually in Norway, and we're about at the same level now as Sweden. And Norway hasn't been fully closed down, and Sweden has not been fully open. They've had a lot of the same advice, but in Norway we've used legal measures to keep this up and going with also prescriptions that you are not allowed to do so and so. In Sweden, they've said we advise people to do so and so. So I think in a way, the rapid installation of the measures were very useful in this situation. And that was actually a political action taken. And I think it's very interesting to evaluate what has happened in the aftermath here. We still don't know the final outcome of this. There are still a huge uncertainty connected to how this virus will develop further. Will we have this big autumn wave or will we not? If there is a change, a mutation of the virus, it can be much more serious and we might need to install measures again.
Just going back to Sweden, though, there is a radical difference in the effects of your two policies, although they're not that different. Sweden has had nearly, I believe, 3,500 fatalities. Is that correct?
4,000 people are died now in Sweden.
4,000. Their population is double yours. Nonetheless, you have only had 250 fatalities.
Yeah, that's true. So there's a huge difference, and of course they say we got it into the homes for the elderly. That's what they say as a main reason. But I think that's just a reflection that they also had a much wider spread in the society, and they allowed for that to happen in the beginning, to say that having a more controlled spread is also helpful to build up a herd immunity in the society. And they were always leveling so that they didn't have a overstretched health care services. They've always been able to deal with the numbers they had to deal with in hospitals. So that has been like the level that they were trying to adjust according to. But numbers are going down in Sweden as well now, but slowly.
Interesting. In general, I have the impression that there was not a great deal of advanced coordination among members of the EU or European nations or even the Nordic countries in responding to the coronavirus. Is that correct, or was there a good deal of initial coordination?
Yeah, there has been. We have a very good relationship between the Nordic countries, and we're actually on the phone with the state epidemiologist or people like me in my position in Finland, Sweden, Denmark, and Norway, and sometimes also Iceland jumps in. So we have we know each other well, and we have had a very much of the same thinking. And at the same time, we've seen that there have been differences between the ways this has been dealt with. In Sweden, it's very much dealt with by the authorities, the professional authorities. In Denmark and Norway, the politicians took over around the same time, around 10th, 12th of March, and partly in Finland as well, which is a bit like a hybrid between Sweden and Denmark, Norway. So there's a good understanding, and at the same time, a striking difference now when you see the results. And when you compare also to the different EU countries, it's been like, I think, very difficult for the EU to really organize this in a common EU way. People have done their own things within their countries. They've closed their borders and we're thinking of each and every country. And there has been, I think, a lack of solidarity across, even though we have, we've seen Germany helping with some patients from Italy. Norway have actually sent a team, an emergency medical team to Italy to support some of the hospitals there, which is an EU invention. So there were like 20 health personnel staying there and working there for like 3 or 4 weeks. So there has been some minor change of personnel and solidarity across, but everybody has been like a bit overwhelmed, and I think have had enough with themselves. And the EU have been trying to come up with measures and ways of doing this coordinated, but they have struggled. That is my opinion.
And what are you saying in terms of a vaccine? You think there will be a vaccine in the near future?
I think there are good prospects for that. There are, as far as I know, around 10 candidates now being tested on humans, and a number of like 100 candidate vaccines also in the pipeline. And from the EU Agency for Medicines, they stated that they hope there will be a working vaccine by end of this year that can maybe be used in minor amounts for specific risk groups, the elderly and health personnel. And a full production will probably take another half a year or a year. So mid next year, hopefully more like a mass vaccination can occur. I think there are good prospects for that. They have learned a lot, from previous MERS and SARS virus outbreaks. The problem was that they stopped developing the vaccine. When they stopped, when the SARS epidemic was over, the interest was over. So I think it's again a learning, what can we do? This is something that we definitely need to have as far as possible close to really testing on a new situation. But they have benefited from the work that was done on the SARS and the MERS vaccine, which are, the same family of the viruses, the coronavirus family.
And you're saying that basically there is a feeling that there will be a vaccine available by the end of the year in limited quantities.
That's our hope. And I think we have to somehow govern according to that. And I think we have to stay and stick to rather tough societal measures until that happens. Because we see the effect of letting this loose with a reproduction number without measures being like 3, meaning 1 will infect 3 others. That's too serious. We cannot let that go loose in the society. So that's why I think, and we've seen, I would say, a strikingly effect of these measures that have been taken about social distancing, about hand washing routines, about sneezing and coughing routines. And we've seen in Norway a very interesting, very, very sharp decline also in all other infectious diseases. Both sexually infectious diseases, about respiratory infectious and food and waterborne diseases, going down with 61% from last year's April to this year's April, showing it's the way we live together that also causes all this disease spread. So I think there is something here which is something really to learn from also in the future.
That's fascinating. That's great. Let's see, I have a couple other questions here. What about travel to Norway in the near future? I do think your borders are essentially still closed, aren't they?
Yeah, closed in a way that you have to stay for 2 weeks in quarantine.
But
you can come, and then
you
you can
can
sit
come,
on
but
your
you have to stay in
you have to
quarantine.
sit on your hotel quarantine for 2 weeks. So it's not really a summer for tourists to Norway. And Norwegians are advised not to go abroad themselves, otherwise they have to be in a quarantine when they come back home. So the request, or what can you say? Our Prime Minister has said that she advises everybody to have their holiday in Norway this year.
I can understand, and that well, not a bad advice. One other question here, and again, going back to a very practical point, which is quite in debate here in the United States. What is your opinion on the use of masks?
Yeah, that's a very interesting question. In the beginning of this pandemic, I took a picture just for my collection from the, I think it was a meeting in the cabinet of South Korea, with everybody sitting with face masks and protection gear for infections. I thought it was funny. And now we've seen these masks. They are coming from the East, and they've come into Europe, and they've even now installed in Germany. That is an obligation. If you go to shops and public transport, you should wear a mask. And even in Norway now on airplanes. And it's not an obligation from our side, but SAS have said you should wear a mask when you are in the airplane. There is very poor evidence for wearing masks for any effect of that in public. And we're actually now doing a systematic review on that ourselves. And we are counting then the numbers needed to mask to prevent one case. That's a huge number, I'll tell you. And almost all other measures are more effective. So it's not very effective in the community, but it's very effective to use it when there is a high spread in like certain hotspots, or in the homes for the elderly, of course, in the hospitals as well. But we're working on that, and I don't think there will be a community mask obligation in Norway anytime, as long as the spread is low like now.
Very interesting. Very interesting. Well, I think our time is running out, and this has been fascinating. And we hear what you're saying in terms of international cooperation, and at the American-Scandinavian Foundation, our founding premise is on the importance of international exchange and cooperation. So we're right there with you. Before we close, I'd like to thank the team at ASF and Scandinavia House who made this production possible, and that's Lori Fredrickson, Kyle Reinhardt, and Sally Yurkovich. I'd also like to thank the many supporters of the American-Scandinavian Foundation, and notably for those programs at Scandinavia House, the support of the Barbara Osher Pro Suecia Foundation and the Norwegian Cultural Fund are terribly important. And very importantly, I'd like to thank Dr. Forland. You have had a busy day. You've told me you've been on, this is your third webinar today.
Yeah, that's true.
Crossing borders all over the place. So we're very fortunate to have had you with us, and it really has been very illuminating. Thank you very, very much. And thank you to all of you who have tuned in for this. And I hope you'll come back. We'll be talking to other nations about their response to the coronavirus, and there are many other programs. Again, I encourage you to check out our website, scandinaviahouse.org, and take advantage of all of our programming. And now, please be safe. And Dr. Forland again, great thanks.
Thank you very much. Thank you for having me. Bye-bye.